Thank you, Dr. Namita. I'd like to invite Professor Dr. Namita Arora, my dear friend, for this lecture. She's going to talk about neuromuscular monitoring, a very important topic. And she has got keen interest in difficult airway neuroanesthesia and is a faculty and course director with me for ATLS program. Welcome, Dr. Namita. And I would like to hand over the lecture to you now.
Thank you so much, Nija.
Welcome.
I bring greetings from APPEC2023, and I'll be talking about neuromuscular monitoring. So, talking about neuromuscular blocking drugs, do we use them routinely? Yes, of course. What a question you would say. We use neuromuscular blocking drugs routinely. And do we not see incomplete reversal in clinical practice? Well, sometimes, yes, we do. Do we use neuromuscular monitoring routinely? There'll be silence and yes. No, we don't use neuromuscular monitoring routinely. But why? In spite of seeing incomplete reversal. Is it because it's complicated? Is there a hesitation or laziness to use it? Is it time consuming? Or we think it's okay, we can manage without it? I think all the reasons. But standard anesthesia practice, when we are using neuromuscular blocking agents, we are using them to facilitate intubation and to improve surgical conditions by enabling muscle relaxation. However, residual neuromuscular block is seen and it is defined by the presence of signs or symptoms of muscular weakness after administration of the blocking agents, even when neuromuscular blockade is reversed in the operating room. So it's a serious thing. Post-operative residual neuromuscular blockade occurs in 40 to 60% patients receiving the agents. The contributing factors are wide variation in duration of action of neuromuscular blockers, lack of or inappropriate neuromuscular monitoring practices, and poor understanding and training regarding post-operative residual neuromuscular blockade and neuromuscular monitoring. And it's not surprising that the incidence of critical respiratory events in patients with residual block is 51% compared to only 16% when they achieve full recovery. So it's very essential to ensure full recovery, because residual block is likely to cause upper airway obstruction, impaired coughing and swallowing, pulmonary atelectasis, aspiration pneumonitis, hypoxia, weakness, diplopia, and awareness. And it can potentially lead to increased hospital stay and costs. And education and training on the use of neuromuscular monitor, it has been shown to decrease the incidence of adverse respiratory events. And a consensus document was produced by the Association of Anesthesiologists of Great Britain and Ireland in 2020. It recommends a peripheral nerve stimulator is mandatory for all patients receiving neuromuscular blocking drugs, and a peripheral nerve stimulator monitor should be applied and activated immediately after induction of general anesthesia, but before neuromuscular block until recovery from blockade and return to consciousness. So it has come in a consensus document. It is time it becomes an essential monitoring. It's not going forward. So before talking about the monitoring, let us first understand what's happening at the neuromuscular junction. This is a typical neuromuscular junction. It's okay. This is the motor nerve fiber going on to the motor end plate. The action potential comes from the nerve and it stimulates calcium entry into the nerve, which in turn causes acetylcholine release, which then the released acetylcholine at the synaptic cleft, it then reacts with the nicotinic receptors, causing an influx of sodium and muscle action potential, leading to muscle contraction. And the termination of action is by acetylcholine esterase, which metabolizes the acetylcholine. So what is the principle for nerve stimulation monitoring? A single muscle fiber responds to a stimulus by all or none phenomena. Now, what is this? When one is stimulated, there is a specific current beyond which the nerve is stimulated. It is either not stimulated when the current is below threshold, and then it is completely stimulated. And response of the whole muscle depends on the number of muscle fibers stimulated. And if the nerve is stimulated with sufficient intensity of current, then the maximum response is triggered. That is, all the muscle fibers are stimulated. And after administration of neuromuscular blocking drug, the response seen is proportional to the number of fibers blocked. And the type of response reflects the type of block.
Sorry to disturb you, Dr. Namita, you're not audible.
Hello, am I audible now?
You're audible, but it's very low. The volume is like really low. You may start, let's see.
Yeah, can you hear me now?
Yeah,
Hello?
tell me. Okay, better.
Where did you
Yes.
miss? Where did you miss my sound?
Yeah, just now when I told you. Yeah, please go ahead.
How does one go back? Okay. Okay. So when one is testing with a nerve stimulator, yeah, the stimulus should be monophasic and have a rectangular waveform, the length of pulse not exceeding 0.2 to 0.3 milliseconds. A pulse exceeding 0.5 millisecond may stimulate the muscle directly and cause repetitive firing. And the stimulation should be at a constant current. Hence, a battery source should be used. And for safety reasons, the nerve stimulator should be able to generate a current of 60 to 70 milliamperes and not higher than 80. there can be two types of devices used, either subjective or objective. This is a simple peripheral nerve stimulator. I think people of our generation are familiar with this. It's a simple device which has two electrodes, positive and negative, and it has got a current generator. And once these two terminals are attached to a peripheral nerve, one can see the movement at the adductor pollicis. So here there is no numerical value given to the degree of contraction of the muscle. We only assess visually the response of the stimulated muscle. It is definitely more reliable than the clinical test that we use after reversing the patient. However, cannot completely prevent post-operative residual neuromuscular block. Then comes a typical objective or quantitative monitoring device that we have in our modern monitors. It's a regular NMT monitor. It quantifies and displays a numerical value for the evoked responses. We generally use the ulnar nerve at the distal forearm to monitor the contraction of adductor pollicis. However, if the arms are not accessible, then posterior tibial nerve or facial nerve can be used. Coming to the type of stimulus, one has to understand these terminologies. Threshold stimulus is the current amplitude in milliamperes, which generates a response in most sensitive fibers in a nerve bundle to elicit a muscle response. So that is the least amount of current that is required to elicit a response. Maximal stimulus is the current amplitude which elicits a response in all muscle fibers. However, we generally used a supramaximal stimulus, which is 20 to 25% current above the maximal current amplitude, so that all nerve bundles are stimulated throughout the period of monitoring. Then coming to the patterns of stimulation that we use to monitor, it can either be a single twitch stimulation, train of 4, tetanic stimulation, post-tetanic count, or double burst stimulation. So before going to different patterns, I would like to describe the parts of a standard neuromuscular monitor. There is this NMT module with a NMT cable. There is a stimulation cable which is attached to two electrodes, a negative electrode and a positive electrode. One is black, the other is red. Then there is a temperature sensor. This temperature sensor has a slot in this splint, and it is fixed so that it is in contact with the skin to monitor the temperature. Then there is this splint, round splint, which goes on to the thumb for fixing. And then there is a force transducer, which is then attached to this splint so that it is able to quantify the force with the thumb is, the adductor pollicis is contracting. In addition, there is a cable which attaches this module to the machine. Coming to setting up a neuromuscular transmitter monitoring. So you can see here all the connections will be made. The cable is already attached. I'm fixing the electrodes to the ulnar nerve. The negative one goes distally. There should be a gap of 3 to 4 centimeters between the two. Then fixing the adductor pollicis along with the fixed force transducer. I am fixing the temperature sensor to the splint and then fixing the splint to the fingers. Then I will see I am strapping the splint onto the thumb and the fingers. It does not take time. It's not complicated as one thinks. So it's all attached now. And now the cable will be attached. One has to ensure free movement of the thumb. And then this cable is attached to the module. And then the module is attached to the monitor. And you can see that once it is attached, you can see the NMT and TOF ratio being seen on the monitor. So our setup is connected, ready to be used. But remember, it is very painful to give stimulation, supramaximal stimulation to an awake patient. So the setup is ready, but not started as yet. So coming to the stimulus, single twitch stimulation, it's a single square wave supramaximal stimulus lasting for 0.2 milliseconds applied at regular intervals, generally every 10th or 20th second. Here in the diagram, it shows it is every 10th second. And baseline twitch height is measured and compared with subsequent twitch heights. In the modern monitors, there is a reference twitch height which is already there, and whenever we test a single twitch, it is compared to the reference twitch. We don't have to remember the height of the reference twitch. And twitch height begins to reduce when neuromuscular blockers are given. A 75% receptor occupancy is required before the twitch height decrease can be visually perceived. Twitch depression need to be more than 90% for abdominal surgery. And like you can see, it is very easy to perform, but requires knowledge of baseline twitch height. And it's a very crude assessment, as you are not really having a control for every patient. Now, this is the graph that you see on the monitor. When you give stimulation at 0.1 to 1 hertz, then the response is seen. But here it is showing the response with non-depolarizing block. Before the drug is given, this arrow indicates the time when the neuromuscular blocking drug is given. So here the twitch height is maintained. And after the non-depolarizing drug is given, it takes time for the twitch height to come down by more than 90%, and it takes generally around 3 minutes. That is the time that we wait for intubation. However, when it comes to depolarizing block, again, the pattern is similar. There is a decrease in the twitch height. It is just that it happens faster. So the change is only in the time scale and not in the pattern. So if you give a single twitch and you see that there is reduction to 50% twitch height, it indicates nothing. You don't know whether it is a depolarizing or a non-depolarizing block. So that is why it is not considered a very good method of neuromuscular monitoring. But it is still used to first determine the supramaximal stimulus and used with tetanic stimulation for post-tetanic count. We'll come to that and you will understand. However, the disadvantages include it cannot differentiate between the type of block. It requires standardization and calibration of twitch height, and return to twitch height does not guarantee full recovery. Like I told you, starts only once 70% of the receptors are blocked. So you surely cannot use it as a good monitor. So I'll show you how a single twitch stimulation is seen. Here we are doing it manually. Set the stimulating current at 5 milliamperes and checking. So set at manual, checked with 5, it did not cause a stimulus. Checked with 10, it did not cause a stimulus. Again increased to 20. With 20, it showed a stimulus. So I'll show you the screen on which here you can see a twitch height has come and it is showing 98. So when we increased it to 25 milliamperes and we gave a single twitch, it showed a twitch height of 100. So that means this is the reference for us when we are using single twitch. So the stimulus current was 25 milliamperes, which produced 100% twitch height. Coming to train of 4. Everyone is familiar with this terminology, train of 4. It is called train of 4 because 4 impulses are given with a specific pattern. It was introduced by Ali and Associates in early 70s. 4 supramaximal stimuli are delivered at a frequency of 2 hertz. That is 2 stimulus per second. That is 1 every 0.5 second. And each stimulus causes a muscle response because it's a supramaximal stimulus. And the characteristic of the fade from the first to the fourth provides basis for the evaluation. The first response is a control, and when used continuously, it is to be repeated every 10th to 20th second. And if less than 4 responses are present, then the count of the number of responses seen is then called TOF count. That is, if all 4 are present, then the ratio is given. If 3 are present, then it is said that only 3 responses are there. When all 4 responses present, like in a patient who is not paralyzed, only anesthetized, you will find all 4 TOF responses because patient without muscle paralysis will respond to all 4 with full height. So the TOF ratio, that is 4th response to first, is then 1. So here, this is the pattern that is used. As I told you, each impulse is for 0.2 milliseconds and it is a train of 4 is completed in 1.5 seconds and the frequency is 2 hertz. So in a control, that is only anesthetized patient with no block, the TOF ratio is 1, that is all 4 responses are of equal height. Partial non-depolarizing block, the ratio decreases. That is, there is a fade from first to fourth. and is proportional to the degree of block. And the but the depolarizing block does not produce a fade, but it reduces the twitch height of all four responses. So the TOF ratio 1:4 response remains 1. However, the total height is reduced. And fade in TOF is after succinylcholine, if seen, is an indicator of phase 2 block. That is, after scoline, you see features of non-depolarizing block. Now, I think it will become clearer once you see the graph. When the stimulus is given in a control, you can see in a control, all four responses are present and are of equal height. That is, the TOF ratio is 1. The fourth response to first is 1. Here, the non-depolarizing drug is given. After that, there is disappearance. First one to disappear is fourth, then third, then second, then 1. All four disappear, and that is when the intubation is done. And the return of TOF, once the case is going to be finished, is in this order. First to appear is the first, then the second appears, then all four appear, and only when all four appear, we talk of TOF ratio, that is T4 to T1. And then only once TOF ratio is more than 0.7, that neuromuscular block is reversed. And in a depolarizing block, as you can see, this is a control where all four TOF responses are equal. The depolarizing drug is given here, and all four are depressed. And when one is recovering from the depolarizing block, all four are recovering at the same time. So TOF ratio remains 1. However, the height is achieved only once patient is completely out of the depolarizing block. So how do we correlate TOF count and TOF ratio? If TOF count is 0, that is no response is seen, then approximately 100% of the receptors are blocked. If the TOF count is 1, then 90% receptors are blocked. So if we are monitoring TOF intraoperatively, when the TOF disappears, we intubate the patient. And once TOF first response appears, we repeat the relaxant. That is, we maintain more than 90% receptor blockade. If the second response appears, it is 80% receptor blocked. Third appears, 70% blocked. And when the fourth appears, that means less than 70% receptors are blocked. And TOF ratio is more than 9. That means ready for extubation. So once all four TOF responses are there, that is less than 70% receptors are blocked, patient can be reversed. So when it comes to the TOF ratio, another thing to understand, this is correlation of TOF ratio with what we normally do, the clinical assessment. So here you can see, when we feel that patient is able to lift his head for more than 3 seconds, open their eyes widely and stick out their tongue, but vital capacity and inspiratory force are often still reduced. They have more than 0.4 and up to 0.6 of TOF ratio. So still significant amount of receptors are blocked. Only once TOF ratio is 0.8 to 0.9, that patient is still feeling still adequately reversed, but still there may be generalized fatigue. So when you are doing neuromuscular monitoring, this battery is low. So when you are doing neuromuscular monitoring, ensure that TOF ratio is more than 0.9. Now I will show you how to monitor So once you look at this, the TOF has been set up and it is not started. It will started only once patient is anesthetized. So here we are inducing the patient, and only once patient is induced that neuromuscular monitoring is started. And keep watching for the TOF ratio. It is 100% because all the 4 responses are present and of equal strength. Relaxant given, the TOF ratio is slowly dropping. It has become 82, 76. It will slowly drop to the TOF ratio will disappear and TOF count will come. TOF count will then come to 3, then 2, then 1, and that is when the patient can be intubated. Wash after wash. Now this is at the time of reversal. So you can see that TOF count has started appearing. It was 0 initially. It has come to 1, then 2, then 3. Now TOF ratio, because all 4 responses have come, so now it is depicting the ratio. And reversal agent has already been given to the patient. And keep observing, the TOF ratio is coming up. One is observing the patient for recovery. And only once the TOF ratio crosses 0.9 that we will extubate the patient, and patient will be fit to go to the post-operative room with no risk of post-operative pulmonary complications. It will slowly come up. So patient is now ready for extubation. So what are the advantages of Trainor-4? There is no need for a controlled twitch. One can differentiate between depolarizing and non-depolarizing block, can detect a phase 2 block, that is if the drug given is a depolarizing drug, but the block seen is on pattern of non-depolarizing, then you know that phase 2 block has set in. And advantage is it is less painful than tetanic stimulus. However, this too has disadvantages, like it has it is of no help to detect degree of block at 2 extremes. That is, if the block is very deep, then there is no response in TOF, and there is no way to know how deep is the block. Same with complete recovery. If you find all 4 responses, then it is difficult to know if there is complete recovery. And visual observation cannot differentiate between ratio of 0.4 to 0.5. So there is something called tetanic stimulation, which helps It was initially developed to understand recovery. However, because technique stimulation is very painful, so now its application is only in PTC to assess very deep block. So what is done in technique stimulation? A burst of rapid stimuli are given of the frequency 50 to 200 hertz, and each lasting for 0.1 millisecond and maintained for 5 seconds. It's critical that it is maintained for 5 seconds, because if more than that it's given, then it is not indicative of block, but indicative of muscle fatigue. Then one monitors the strength of contraction for subtle fade. Usually 50 hertz is used, as with higher frequency, there may be fatigue, and it is extremely painful. So the graph looks like this. When stimulus is given, this is normal twitch response. Then it is given at higher frequency. This is given at 2 hertz, then increased to 50 hertz tetanic stimuli given for 5 seconds. And then follow this up with after a gap to normal twitch. So here this is normal. In a normal muscle, after initial single twitches, if tetanic stimulation is given, and then after giving some rest to muscle, if normal stimulation is given, then there is no potentiation. However, in non-depolarizing block, here one can see there is this is depolarized. This is a non-depolarizing block. Here in control, normal twitch followed by tetanic stimulation. Then there is normal height of the response. However, after moderate non-depolarizing block, there is post-tetanic potentiation. And in tetany also, it is not sustained. Here, tetanic stimulation, the response is sustained. However, when there is non-depolarizing block, the tetanic stimulation shows a fade. However, after a gap, when again stimulation is restored, then there is post-tetanic potentiation, and this is higher than the amplitude before when the muscle was normal. However, the response for depolarizing block, there is only a decrease in the height. However, there is no post-tetanic potentiation. And a thing to remember is this post-tetanic potentiation lasts for only 60 seconds. So what is the mechanism for this potentiation? Whenever tetanic stimulation is given, it leads to a transient exaggerated release of acetylcholine that briefly shifts the ratio of acetylcholine and the blocker at the motor end plate in favor of acetylcholine, because excess acetylcholine is released. Even if no twitch response was there prior to tetanic stimulation, that is, I'm talking about deep block, if there is no stimulation prior to the block, after tetanic stimulation, one may find a twitch, because that is because of the excess acetylcholine, which was able to displace the neuromuscular blocker and produce a response. That is called post-tetanic potentiation. And tetanic stimulation by itself is a presynaptic event. Large amounts of acetylcholine is released from readily available stores in the presynaptic nerve terminal. Although these stores become depleted, the muscle response to tetanic nerve stimulation is maintained in a normal muscle. As there is a lot of margin of safety, there is excess amount of acetylcholine that is released. However, with non-depolarizing muscle relaxants, this shows a fade. It is very painful, so has limited use. It is used in DBS and post-tetanic count. Coming to post-tetanic count, it helps to assess a very intense neuromuscular block where we are not getting any TOF response. And this is helpful when we want for surgeries where very deep block is required, where absolutely no movement by the patient is to be permitted, like in retinal surgery and in neurosurgery. It is, like I told you, it's based on post-tetanic potentiation. So a tetanic stimulation of 50 hertz is given for 5 seconds, and it is followed by 10 to 15 single twitches given at 1 hertz starting 3 seconds after the tetanic stimulation. And the total number of post-tetanic twitches that we see are inversely proportional to depth of the block. Deeper the block, less the post-tetanic count. As the intense block dissipates, more and more responses to the twitch stimulation appear after the tetanic. So this can be depicted here. This is stimulation. One is giving a stimulation here, followed by tetanic stimulation. And when we give a tetanic stimulation, then post-tetanic, after single twitches are given, there is a response. This is post-tetanic stimulation. So here, this is a very intense block. So here, no TOF is visible. There is zero response to TOF. There is no response to tetanic stimulation, and no response to post-tetanic stimulation. But from intense, when it comes to deep block, then one response appears, although TOF is zero, but one response appears after tetanic stimulation, which is because of post-tetanic potentiation. Again, TOF remaining zero, one gets 3 responses when the block is becoming lighter. And thing to notice here is that only when one gets post-tetanic count of 8, that a single response appears in TOF. So this is the level at which we get other surgeries done. When there is a single TOF response, we give the repeat neuromuscular agent. However, when a very deep block is desired, then we can use PTC and keep the patient under very intense, deep neuromuscular blockade. Post-tetanic count, again, like I told you, is used for profound block. So PTC should be 3 or less if a deep block is required for clinical reasons. At 6 to 10 PTC, the return of the first TOF is seen, which is most often eminent. As tetanic stimulation should not be performed more often than every 6 minutes, this stimulation pattern cannot be applied continuously. So if you see the module and you start PTC, it will give only single PTC, single stimulation followed by PTC, and it does not get activated till 6 minutes pass. So it cannot be automated to firing continuously. Coming to double burst stimulation, it was developed with specific aim of improving manual, tactile, or visual detection of residual non-depolarizing block under clinical conditions or during recovery and immediately after surgery. So it is done, unlike PTC, which is used for very intense block, double burst is used for very light block. When in TOF, you have all 4 responses present. TOF ratio is 1, and you are not able to find any residual block. So here, 2 short bursts of 50 Hz tetanic stimulation is separated by 750 milliseconds with a 0.2 millisecond duration of each square wave impulse. So the number of bursts can vary. One can give a DBS in a 3-3 mode, that is 3 impulses in each of the 2 bursts, or one can give in a 3-2 mode, that is 3 impulses followed by 2 impulses. The individual twitches elicited by each burst blend together and are felt as one single muscle contraction. And the response to DBS is 2 short muscle contractions. So when you are giving 3 contractions, in the first burst, it is seen as single contraction. And the fade in the second burst is compared to the first to look for evaluation. So unlike TOF, when you have TOF, which is showing all 4 responses, when you are using DBS, one can visually see the difference between the first burst and the second burst. In a partially paralyzed muscle, the second response is weaker than the first and responds to the typical TOF fade. When measured mechanically, the TOF ratio closely correlates with DBS, and DBS compared to DBS, 3-3 tactile detection of fade is slightly improved with DBS 2. So this is how DBS is given. This is the stimulation. You can see all 4 responses are present. This is control. And when DBS is given, again, both the impulses are seen as equal. However, here again, in control, you find all 4 are equal and this response is exaggerated. But when patient is recovering, you can see that when the TOF is showing slight difference, there is a very clear difference perceivable in the 2 DBS responses. So when you are visually seeing this at 0.7 TOF ratio, one cannot visually differentiate between the first and the 4th response of TOF. However, when you give DBS, one can clearly differentiate the difference, and that is how when the block is between 0.7 to 0.9 TOF ratio, DBS is helpful to differentiate. So tactile evaluation of response to DBS is more accurate in detecting fade compared to TOF. However, DBS is still insufficient to exclude reliably residual paralysis according to a TOF ratio between 0.6 and 0.9. So there is no substitute to objective clinical monitoring of the patient. There are other factors which affect neuromuscular block, like increasing age, cardiac, liver, and renal dysfunction, hypothermia, use of halogenated volatile anesthetic agents, and infusions of neuromuscular blocking drugs. So the key takeaways from this presentation are: it is difficult to assess recovery from neuromuscular blockers to rule out residual block. There is good evidence-based practice that dictates that neuromuscular block should always be assessed using a quantitative monitoring. And to exclude clinically significant residual block, the TOF ratio should exceed 0.9. Thank you.
Thank you, Dr. Namita. It was a very lucid talk, very explained extremely well. I'm very sure PGs have understood it, and that fear of not being able to use it would not be there. Basically, the initial choices that you gave as to why are we not using it, actually it's because of all of them that one doesn't use it, and that fear of I don't know, main nahi kar paungi ya paunga, because it's something new and have not been using it. So it's been explained very, very well. And if there are any questions, Dr. Namita, Saraswat, are there any questions?
Within has taken over.
No questions, ma'am.
Okay. Okay. Thank you. I was actually able to and I urge postgraduates and all residents in my theater to use neuromuscular monitoring so that we are familiar with it. The more we use, the more familiar we get. And like we are getting used to ultrasound for improving blocks and for reducing the complications, I think it is high time we get used to neuromuscular monitoring and not give a drug unless we are monitoring its effect. Thank you.
Yes. Thank you, Dr. Namita. Can't be emphasized in a more innovative fashion. Thank you.
Thank you, ma'am. Thank you for this wonderful lecture. And I thank the speaker for the valuable contribution to APPEC2023. We'll move to the quiz 2. Can we have the first question, please? Yeah. So the first question, here it goes. Evaluation of which pressure during ventilation of obese patient in steep Trendelenburg position is a harbinger of barotrauma? A, airway pressure, B, transpleural pressure, C, end-tidal carbon dioxide, or D, transpulmonary pressure. Coming on to the next question. The chief concerns in robotic surgeries in steep Trendelenburg position are A, ventilation strategies and extubation, B, difficult access of patient, C, protection from the pressure injuries, or D, all of the above.